Hello and welcome to your lecture. In this video, we're going to be covering content in chapter 12 on the cardiovascular system. This chapter starts on page 374 in your textbook. So we're going to go over anatomy of the heart, and then we're going to go through blood flow. So the adult heart rate is between 72 and 82 beats per minute, or BPMs. That's approximately 3 billion beats in a person's lifetime. This muscle, okay, your heart is a muscle, specific tissue type. If you recall from the tissue chapter, one of the muscle types is cardiac muscle, and the only place that you find that is within the heart. Due to its constitution, it is a fatigue-resistant organ that's about the size of your fist. It weighs less than the combined weight of 2 baseballs, or 8 to 10 ounces in women and 10 to 12 ounces in men. The heart is located within your thoracic cavity, directly under the sternum, or the breastbone, which is centered within the chest. Your heart is within the mediastinum. The mediastinum is one of your anterior body cavities, if you recall that from chapter 1. It sits in front of your vertebral column also, and situated between your lungs. It's anchored into the mediastinum by its attachments to the diaphragm, the sternum, and the ribs. It has a broad base, which is actually the more superior portion of the heart. And then it has an apex, or a pointed portion that kind of points cattywampus, if you will, or diagonally towards the axillary region on the left side of your body. The pointed apex portion of the heart is formed by the left ventricle of the heart. And we'll go through the anatomy of the heart here in a minute, but it lies approximately at the 5th rib, this apex, and points down towards that left hip. Again, it's like pointing diagonally toward your left axillary region. The heart has a couple functions that we need to understand, okay? One of its primary roles is to serve as the pump or it is a primary role to serve as the pump for the vessels in the blood. So we can say that indirectly, it's transporting oxygen, hormones, and nutrients by way of this. Let me delineate here too, when we talk about circulatory system or cardiovascular system. The circulatory system is the heart, the vessels, and the blood. The cardiovascular system is the heart and the vessels. So when we're talking the pump, the heart, and all of its hoses that will actually house the blood, okay, that's how we say it's a transport system. It rids the cells of carbon dioxide and waste. It helps regulate body temperature by way of vasodilation and vasoconstriction. Vasodilation is the expansion in the diameter of the vessels. Vasoconstriction is the opposite of that. It's the constriction of the diameter and the reduction of the diameter of the vessels, or the hoses, or the tubes. It's definitely one way that the body maintains its acid-base balance, or the buffering of the blood obviously happens within this system. And it assists with immune system function due to, well, many factors. But one really important factor is that the plasma is generally where we're going to find antibodies floating around. So here's a picture of the location and size of the heart. Again, it's like the size of your fist. It sits behind the sternum in the mediastinum. The mediastinum is the anterior body cavity that sits between the pleural cavities, which are the cavities that house the lungs. And you can see by this diagram in this picture how I was mentioning the base of the heart is like the upper superior portion of the heart, whereas the apex, or the point, is pointing over toward that left axillary region and sits about the fifth intercostal space. That's relevant when you're trying to listen to heart sounds. So let's talk through the chambers of the heart. First of all, you have two chambers on the top. These are your atria, or each one individually is an atrium. And then the bottom chambers, you have one on each side. These are the ventricles. The atria and the ventricles are lined with endothelial cells, which will allow the blood to flow smoothly within the chambers. We have something called an intraatrial septum. Just by the word intraatrial tells us it's between the atria. Then we have an interventricular septum, which will divide the ventricles. The atria being the topmost chambers, these are low pressure collecting chambers. Within the heart, okay, if now the atria and the ventricles divide the heart in superior and inferior chambers. Then we also have to divide the heart into left and right sides. The blood coming into the right side of the heart is what we call the pulmonary circuit. It's going to bring deoxygenated blood or circulate the deoxygenated blood. It brings it to the heart and then takes the oxygenated blood to the lungs. The blood that's dealt with on the left side of the heart in both the atria and the ventricle, this is called the systemic circuit of the heart. And it's going to deal with the pumping or the flow or the push of oxygenated blood. In this picture, you notice that we took a cross section of the heart and we are looking into the ventricles. You can see very clearly on this picture that the muscle wall of the heart surrounding the left ventricle is quite thick. That is because this ventricle is responsible for pumping blood to the entire body. So it has a long way to travel. There is a little box with more information about this particular information on the slide on page 377, the little tan box, but relevant just to understand the heart's position, because clinically, if you are listening for how heart sounds, you need to know where the heart should be ideally sitting and where you're going to hear the clearest sounds of the heart to be able to assess for any pathology that might be there. So one reason why it is important to understand how the heart actually lies anatomically within the mediastinum and within the chest cavity, which, as we saw in the previous picture, it doesn't sit straight up and down. It lies kind of on its side, not even kind of. So we need to understand that this for a plethora of reasons. If you're doing an EKG, you need to know where to put the pads. If you're listening with the stethoscope, you need to know where to put the stethoscope. If you're performing CPR, you need to understand the location of the heart to help for the best efficiency of this kind of treatment. Okay, so now let's go into the heart valves. This is relevant. Okay, you have 4 valves that are of high significance. You have atrioventricular valves. Look at the word. Atrioventricular valves tells us that these valves will separate the atria, upper chambers, from the ventricles, bottom chambers. This is on both left and right sides. You have 2 of them, obviously. You have a tricuspid valve, which is on the right side of the heart, separating the right atria from the right ventricle. And then you have the bicuspid or mitral valve on the left side of the heart, separating the left atria from the left ventricle. Then you have two semilunar valves. The semilunar valves, as the name would indicate, they look like half moons. Okay, when you look at them in a cross section, that's why they're called that. And if you look in your book on page 377, you're going to see evidence of the shape of the valves and their location and how they are anatomically situated within the heart. The pulmonary semilunar valve will be the valve that leads from the right ventricle into the pulmonary trunk. The aortic valve will be in the aorta that comes out of the left ventricle. Then we hit the valve, then we hit the aorta. Now, the relevancy of understanding where these valves are is because the closing of these valves is responsible for the heart sounds that you hear. So with the AV valves, okay, your tricuspid and bicuspid valves, these are like flaps that are connected, will be anchored to the ventricles by thin fibrous connective cords, okay, or connective tissue called chordae tendineae. And these will connect to, again, the ventricles at a point or location called papillary muscle. When the ventricles contract, then the papillary muscles will pull on these chordae tendineae, which will prevent the valve cusp from swinging into the atria. So it like tightens them up. If the valves were not secure by the chordae tendineae and papillary muscles, the AV valve cusps would push upward into the atria when the ventricle would contract, which would allow the backflow of blood, which is one of their primary roles that we've assigned them. We don't want the blood to regurgitate backwards, which is part of the reason a person would have a murmur. A murmur is the sound made potentially from a prolapse or some kind of valvular insufficiency, or it's not a patent valve. The semilunar valves allow blood to flow from the ventricles to the lungs and to the rest of the body, dependent on which one we're talking about. Each has 3 semilunar or half moon cusps that do not need anchored. When they close, these cusps are strong enough to brace each other. They're similar to a 3-legged stool. Now, the pericardium of the heart. This is a very nice picture to demonstrate the layers of the heart. Okay, the heart muscle itself is the myocardium. The pericardium is the fibrous tissue around it. The innermost layer of the heart is the endocardium. Again, if you're looking at the words, okay, endo, the inside, cardium signifies we're talking about the heart, myocardium, the heart muscle, that middle layer, pericardium around the heart. So when we're looking at the pericardium, we're going to break that down a little bit further. Okay, so the pericardium that sits directly against the myocardium, we also name the epicardium, which makes sense just by the name. There will be another layer to this connective tissue. This is a serous membrane, so there's going to be 2 layers. One that touches the organ itself, which would be its visceral portion of the serous membrane. In this case, it is the epicardium or the serous pericardium, same thing, okay? The part that's touching the myocardium or the actual organ. Then there will be a fluid within the layers of the pericardium. This is serous fluid produced by cells that will line the serous cavity. The outermost layer of the pericardium is the parietal pericardium. Anytime we see a parietal serous membrane, it's a portion of the membrane for a particular organ or organ system that will touch or anchor to the body wall. Outside of that, then we have something called the fibrous pericardium. All of this pericardium helps the heart anchor to the membrane, and then the membrane anchor to the body. Okay, I already mentioned as we walked through that picture a little bit, the layers of the heart. So let's dive into that a little bit. As with most organs that we're going to inspect, we're going to see that there are 3 layers that we identify. The epicardium. This is the outermost layer of the heart, and it is also the visceral layer of the serous pericardium. So you see what's happening there. The outermost layer of the heart, or what we're saying is the outermost layer of the heart, is also at the same time the visceral layer of the pericardium. So it is the serous membrane lining the heart or touching the heart. This is again, called the epicardium. It's composed primarily of connective tissue and fat, which provides an additional layer of protection for the heart. The epicardium is fused directly to the myocardium, and the coronary arteries will lie on its surface. The coronary arteries are the blood supply to the heart muscle itself, which is highly relevant in when someone has a myocardial infarction or some type of blockage within that system. That's when we see heart attacks and stuff like that, necrotic tissue build. Okay, the myocardium itself, the middle layer of the heart, this is composed of cardiac muscle cells called cardiomyocytes. When we explored muscle tissue in the tissue chapter, the cells of heart muscle, okay, a few things that make it special. They have stripes or striations. The striations are created by actin and myosin filaments that help them slide across one another. But the most identifying factor within a cardiomyocyte is the intercalated discs with it, which is a thicker parallel strand within the myocyte. Okay. And these are gap junctions that help the flow of fluid and electrolytes between cells so that the heart muscle can contract as an entire unit, which we call functional syncytium. Syncytium. That's how you pronounce that word. Okay, so also these are branched long tubular cells. Okay. The myocardium makes up about 95% of the heart muscle. The innermost layer then of the heart muscle is called the endocardium. Again, the prefix endo should give us the indicator that we're talking about something on the inside of a lumen or a hollow space or an organ or a vessel or something. It's a smooth, thin layer of endothelial cells. This layer lines the interior of the heart chambers and covers the valves of the heart as well. The endocardium will connect to the great vessels being all big vessels that are coming into and out of the heart. The endothelial cells in the endocardium will help the blood flow smoothly throughout the heart and into the great vessels. Okay, so blood flow through the heart, kind of cool. Let's walk through it. Okay. Remember that I mentioned we have 2 upper chambers. So the heart's divided into top and bottom as well as left and right. Okay, top chambers are atria, bottom chambers are ventricles. The right side of the heart, okay, that means both the right atria and the right ventricle are doing something with deoxygenated blood. So this side of the heart will receive deoxygenated blood from the body and then pump it to the lungs. The left side of the heart, both the left atria and the left ventricle are responsible for the systemic circuit dealing with oxygenated blood, meaning receiving oxygenated blood from the lungs and then pumping that oxygenated blood to the rest of the body. The circuit on the right side, I can't remember if I said it, that's the pulmonary circuit. So right side of the heart is pulmonary circuit, left side is called systemic. So this is how it works. Blood, deoxygenated blood from the superior portion of the body and the inferior portion of the body will flow into the right atria of the heart. It will enter this atria by way of the superior vena cava and the inferior vena cava. The superior vena cava will pull the deoxygenated blood from the superior portion of the body, while the inferior vena cava pulls it from the bottom or inferior portion of the body. Now, there's also a portion of the atria. Well, it's not on here, so I'll let it alone. Sorry. Never mind. Actually, I will mention it's called an auricle. Okay, there's this little extra part on the atria of the heart, not for our purposes. Okay, it's not here, at least I don't see it. Called an auricle. Okay, so it's like this little extra expansive pouching for blood to come in, so that the atria have a little bit of extra room. Anyway, as the deoxygenated blood comes into the right atria, it will then flow into the right ventricle after passing through the tricuspid valve, which again is an atrioventricular valve, anchored to the papillary muscles of that right ventricle by way of the chordae tendineae. Once blood enters the right ventricle, it will be pumped up into what's called the pulmonary trunk, but it has to pass through the pulmonary semilunar valve first. The pulmonary trunk will then branch into a right and left pulmonary artery. These pulmonary arteries are taking the deoxygenated blood to the lung so that it can be exchanged for, so it can do a carbon dioxide oxygen exchange there. After that happens, the blood will come back into the heart by way of the pulmonary veins entering the left atria. Once this newly oxygenated blood is in the left atria, it will pass through the bicuspid atrioventricular valve and enter the left ventricle. The left ventricle then will pump the blood through the aortic semilunar valve into the ascending aorta, pass through the aortic arch, up through some other arteries that are doing their thing. One other thing I want to mention, when we talk arteries and veins, in general, arteries will take blood away from the heart, artery away, and veins bring blood back to the heart. However, the exception to that rule are your pulmonary arteries and veins. They're opposite, okay? And if you walk through this blood flow map, you'll see that again. The pulmonary artery takes deoxygenated blood out of the right ventricle to the lungs for oxygenation. When the blood is reoxygenated, it pulls blood back to the heart by way of the pulmonary veins carrying oxygenated blood and putting it into the left atria. Okay, so the cardiac cycle, one complete cardiac cycle is relaxation, which is diastole, and contraction, which is systole. So when we take someone's blood pressure, we're looking at both of these things, okay, within a cycle. The terms systole and diastole usually refer to what is happening in the ventricles because they are the major pumps of the heart. And a healthy heart, the contraction times are slightly offset when the atria contract and the ventricles are relaxed. When the ventricles contract, then the atria are relaxed. One cardiac cycle will last approximately 0.81 seconds. In general, approximately 2/3 of the cardiac cycle is spent in diastole and 1/3 is spent in systole. So then by knowing this, we can, look at some other measures, one being the mean arterial pressure. This will determine blood flow. It measures the overall pressure, and it is equal to 2/3 of the diastolic pressure plus 1/3 of the systolic pressure, which is what we just talked about, what we just said. So if this pressure were to fall below 60 millimeters of mercury, the organs of the body will become damaged because they're going to lack oxygen. So that's the value of understanding mean arterial pressure. A low blood pressure also means that the body will not receive the nutrient-rich blood flow that it needs. And I think that makes sense as well. During the cardiac cycle, the AV valves and the semilunar valves will make a sound when they close, as I have mentioned. So this is the lub-dub sound your heart makes. The first sound, the lub, is produced when the AV valves close, your tricuspid and bicuspid. The dub sound is produced when our semilunar valves close. If the valves do not close properly, like I had mentioned, if they're not patent, if they're not tightening for whatever reason, there may be a different sound made, and that's what we call a murmur. Most murmurs are harmless and can be caused by rapid growth spurts, particularly in children. Now, that can become different in an adult a little bit, okay? Okay, so one of our primary concerns when we're looking at cardiovascular system is an increased blood pressure, right? We want to make certain that the pumping to organs is appropriate, so we're not damaging organs with a higher blood pressure. And there are many factors that influence blood pressure. One thing you have to understand about blood pressure, yes, we're worried about what's happening within the vasculature as well as the heart muscle itself, like what's the damage being done here. The blood pressure, a large portion of it is regulated by the kidneys as well as a lot of other things. So when we're looking at blood pressure, it's very good to look at what the kidneys and adrenal glands are up to. When we're talking stroke volume, this is the amount of blood that's pumped from the heart. So this is measured in milliliters per beat. Stroke volume is determined by 4 factors: the amount of blood that returns to the heart during diastole. This is venous return, or what we call preload. Also, the degree of stretch in the myocardial muscle fibers when extended. This is called myocardial stretch. The strength of the left ventricle, and then something called afterload, and that is the resistance in the great vessels that are pushing against the blood attempting to be ejected. As the amount of blood that returns to the heart increases, the amount of blood in the left ventricle before it contracts, or preload, increases as well. A large preload will increase the stroke volume. When more blood returns to the left ventricle, the myocardial muscle fibers are stretched more. The increased myocardial stretch will also increase stroke volume. When the myocardial fibers are stretched, the number of cross bridges between actin and myosin filaments in the muscle fibers will increase. This in turn increases the force of the left ventricular contraction. thereby increasing stroke volume. So the relationship between the increased myocardial stretch and increased strength of the left ventricular contraction is known as the Frank-Starling mechanism. An increase in sympathetic nervous system activity can also increase the strength of the left ventricular contraction. As the afterload decreases, a greater amount of blood can leave the heart. Therefore, a low afterload increases stroke volume. Afterload is determined by the mean arterial pressure against which the heart must contract. So the amount of blood pumped from the heart per minute is called cardiac output. Cardiac output is important because it has an effect on blood pressure, cardiovascular fitness level, as well as body temperature. The unit of measurement for cardiac output is liters per minute. Cardiac output is determined by multiplying the heart rate by the stroke volume. Heart rate and the mechanisms that control it, we'll get there, okay? The average cardiac output for an adult is between 5 to 6 liters per minute. Cardiac output is influenced by many factors like body size, exercise, emotions, diet, and physical activity. Emotions are my favorite thing to talk about when we're talking about cardiac output, blood pressure, all of it. Okay. If our emotions are throwing us into some type of sympathetic nervous system response or fight or flight response, blood pressure is going to be impacted. Okay, so when we're talking regulation of the heart, we have to talk about the conduction system of the heart. This has to do with, what is actually controlling the heart rate, and that's multiple factors. The conduction system of the heart is a whole assembly line of electrical impulses that starts at what's called the SA node or the sinoatrial node. This is known as the pacemaker of the heart, and it is responsible for triggering the electrical impulse chain of events that happen within the heart. Okay, and once triggered, will inspire a heart rate of between 60 and 100 beats per minute. The sinoatrial node is specialized endothelial cells within the right atria of the heart. If the SA node fails to fire, then we have the next node in line called the AV node. Atrioventricular should give you an indicator of where that will be in between the atria and the ventricles. Now, if the SA node is dysfunctional, we will be able to pick that up potentially within the heart rate measurement. That's one of the values of measuring that constitutionally. Okay, if we notice a heart rate that's slower, 40 to 60 beats per minute, we might want to look at maybe there's an SA node firing issue. Now, having said that, if your heart beats slower because you're a triathlete, that's a totally different situation, and all of that needs to be taken into consideration. So symptom doesn't necessarily give us diagnosis, right? We have to do some sleuthing to figure out what's up. Now, if our SA node isn't working, okay, and we have a slower heartbeat because the AV node, the backup generator, had to start the impulse, this will reduce cardiac output. If cardiac output is reduced, then we have reduced blood flow, efficiency, oxygen exchange potential, nutrient exchange potential, etc. At the ventricles, if the AV node fails, also the electrical impulse that we'll see is like 15 to 40 beats per minute. When this happens, this is likely when we are going to really notice some other symptoms along the line, and this is where an external pacemaker can be functional. Now, from an external control perspective, like what other regulatory centers are impacting the heartbeat and its output. Okay. This is where we're going to look at the medulla. The portion of the medulla that controls heart rate and the strength of contraction is sometimes referred to as the cardiac center of the brain. The cardiac center will accept input from both the sympathetic and parasympathetic branches of the autonomic nervous system. Okay, that statement was really important. Yes, there's sympathetic nervous system control, but there's also a parasympathetic tone that must be maintained. If parasympathetic tone becomes interfered with, sympathetic tone will get out of control, and that's going to not work out right. So the sympathetic nerve fibers will stimulate the SA node, the AV node, and other parts of the myocardium. The parasympathetic nerve impulses, which come from the right and left vagus nerves, will innervate the SA, AV, and parts of the atria. The sympathetic nerves will release norepinephrine, which will activate beta-1 adrenergic receptors in the heart. These receptors will stimulate ventricular contractility. So activating them will cause an increase in rate. Acetylcholine, which is released by the parasympathetic nerve fibers, will have the opposing effect and slow down the heart rate. So let's just talk about that for 1 second. Again, we have sympathetic and parasympathetic nerve fibers. Okay, these are autonomic nervous system divisions that you're not consciously controlling, responsible for either fight or flight responses or wine and dine responses. So either, getting ready to run, fight, flight, or calm down, right? Or it's time to take a break. They have to be working synergistically in order for the system to work. So if you are someone that's chronically stressed and you cannot pull that parasympathetic tone down, that's going to have an impact on heart rate, blood pressure, etc., all the things downstream. The cardiac center of the medulla will continually monitor and adjust the rate, the strength of the contractions, the stroke volume, and vasodilation and constriction. So it's doing all of these things all at the same time. It will stimulate the sympathetic branch when the body requires an increase, and it will stimulate the parasympathetic branch when there's a decrease needed or noted. The trick here, though, is to understand that, and this is where the emotional part comes in, right? Emotions, the threat or the fear or whatever doesn't have to be real time. You can just have a thought, which can inspire and trigger all of these events to happen, which is super cool. So, and that's where we talk about higher brain centers, right? That's the limbic system. Anytime you hear limbic system, okay, that's a higher brain center where we're really integrating processing memories, but emotions as well. So from here, from thoughts and emotions and feelings or anything that gets triggered as a memory of a past trauma or episode can inspire these centers to do what they need to do as well. When we're talking about exercise, the motor cortex will act through the hypothalamus to help regulate these guys. Also, changes in body temperature. The hypothalamus is partly responsible for that. So if we need a body temperature change up or down, hypothalamus can alter the rate, cardiac output, and then blood flow to tissues as well. When we talk sensory receptors, these are really paramount into how this information gets to these brain centers. So we have something within these systems called baroreceptors. Baroreceptors are going to be specialized sensory cells placed throughout the system to detect changes in pressure. We also have something called a chemoreceptor. Chemoreceptors are super cool. You have them both in the vascular system, but also the nervous system to detect changes in pH in certain areas. Then we have mechanoreceptors. These are sensitive to mechanical stretch in tissues. These are, we have these in our muscles and our tendons. So we can kind of have proprioception and body awareness without having to think it through step by step. So some factors that will contribute to your heart rate, this is going to be hormone regulation, things like epinephrine and norepinephrine, which are what we call catecholamines. These are produced primarily at the medulla of the adrenal gland, and they have a direct connection to sympathetic nerve fibers. This is like adrenaline, right? This is where that's connected to. Thyroxine, that's a thyroid hormone. Exercise, of course, will impact heart rate as it should. If we're moving more, we're going to need cardiac output to keep up, right? We need the blood flow to be what it is. Age will matter, gender matters, and our fitness level, as I had mentioned previously. Okay, so this is a nice little chart if this works for your head. It's also on page 386 in your textbook, so you can look there and reference it there. All the things that are going to have an impact on that cardiac output in that response. Just for kind of like a little super side note here so that you can kind of walk through and think things through. Which part of the brain contains a region known as the cardiac center? And then a couple hormones that would be involved that would impact the heart rate. Okay, and you can get that off of that chart. We mentioned them already. Now let's talk through the conduction system of the heart. Okay, I already mentioned this because we had to touch on it with the SA node, the AV node, right? But we're going to go through the entire conduction system of the heart because this is really the electrical part that regulates the heart. And if it's electrical, it's being controlled then by the nervous system. So this will control the heart rate and contraction strength of muscle tissues. There are two areas of nodal tissue. And a network of nerve fibers that are responsible for polarization. Remember, we went over this. Okay, anytime something is polarized, you have two opposing ends. Okay, it's resting potential energy. Having polarity allows us to have that potential to do work as the poles neutralize. That neutralization of polarity is called depolarization. Okay, that's going to create the work. That's going to give the energy to do the work, which in this case would be the contraction of the cardiomyocytes. When something is repolarized, then we put the poles back in place. We put the opposing ends back in place so that the potential to change and do work is still there. Okay, so here is our conduction system of the heart. Okay, so within the conducting system of the heart, it begins with the SA node or sinoatrial node. This is known as the pacemaker of your heart, and it's located at the superior portion of the right atrium. Then it will have what's called an internodal pathway that will connect or transmit the impulse to other areas. The primary internodal pathways will conduct the signal to the AV node or atrioventricular node. Again, by the name of it, that should tell you that it sits between the atria and the ventricle. From there, there will be a branch that will travel into the interventricular septum. it will, this branch is called the bundle of His, and right at that point, it's going to break into the right and left bundle branches, which will then wrap around the ventricle on each side of the heart and end in what are called Purkinje fibers or terminal branches. Another portion here that comes off of the SA node is Bachman's bundle, and that's going to help that left atrium contract. Now, when we're talking blood vessels and circulation, the vessels are actually, if you've not thought it through, which most of us don't, okay, super cool conducting system. We have arteries and veins, right? Arteries primarily are carrying blood away from the heart that's oxygenated, so the tissue can get oxygenated, and veins do the opposite. They pull deoxygenated blood back to the heart. Now, this is, like I had mentioned previously, opposite in pulmonary arteries and veins. But as we're going through arteries and veins, we're going to talk through some of the anatomy of the vessels themselves. Now, the name of a vessel will change with its size, diameter, and composition. So let's talk through some of that. So we primarily have arteries, capillaries, and veins. Arteries will branch into smaller, what are called arterioles, which then will connect to capillaries or turn into the capillaries. Capillaries are where the gas exchange will take place, the fluid, the electrolytes, a lot of stuff happens in a capillary bed, and they're super cool the way they work. The capillaries then will kind of run right along, keep going, and turn into what's called a venule. These are the smallest veins. And again, this part of it, due to how it's constructed, will take the oxygenated blood back to the heart on that side of the capillary bed. All blood vessels, with the exception of the capillaries, are composed of 3 layers and surrounded by or surround the lumen of the vessel. Okay, the lumen's that inner part. Okay, the tunica intima is the innermost layer, composed of a single layer of squamous or flattened epithelial cells over a sheath of connective tissue. The tunica intima, also called the endothelium, will provide a smooth, frictionless surface that allows blood to flow smoothly through the vessel. The tunica media, that's the middle layer. It's a thick layer containing smooth muscle, elastic fibers, and collagen. The smooth muscle cells in this layer are directed by the sympathetic nervous system to vasodilate and vasoconstrict. This will allow the blood to flow to be increased to certain tissues and decreased to other tissues as needed. So we mentioned vasodilation and vasoconstriction. Vasodilation is when a vessel has the capacity to expand its diameter, and constriction is the opposite of that. When a blood vessel is able to dilate, okay, we can put more fluid through the hose, right? More water through the hose, more blood through the vessel. When we do that, we produce less resistance. Thereby, we can drop blood pressure by dilating a vessel. And then the opposite is true when vessels constrict. So the tunica externa, the outermost layer of the blood vessel, is composed mostly of fibrous connective tissue, and this will serve primarily as a support. Okay, let's see if I wanted to show you anything on here. There's a nice chart on page 388 in your chapter that separates the vessel type, talks through their structure a little bit, and then the function. One thing I want to point out here is that, okay, the venule, smallest size of vein, will eventually turn into a vein, which is a larger vessel. The veins themselves, again, 3-layered, thin-walled, and they will have valves. Okay, when we have venous valve issues, this can contribute to or is the reason for like varicosities, varicose veins and such. Okay, now a primary difference between arteries and veins overall. Arteries tend to be strong, thick, and elastic, where veins are thinner and less elastic. The pressure in the artery is high, and the pressure in the vein is low. Generally, arteries have smaller lumens, whereas veins have a little bit larger of a lumen. Arteries do not have valves, and veins will have valves. So when we're talking, then some of the primary vessels of the cardiovascular system, we already mentioned the inferior and superior vena cava. They come into the right atrium. Inferior vena cava brings deoxygenated blood from the lower part of the body. Superior vena cava brings deoxygenated blood from the upper part of the body. The aorta, that is the great vessel that is going to be the first part of the systemic circulation, leaving the left ventricle, carrying freshly oxygenated blood, being pumped to all parts of the body. Now, as we can see from this diagram, as the vessel goes further away from the heart in general, okay, the aorta, by the way, has multiple divisions in it, okay. The first part out of it is ascending. The arch is called the aortic arch. And then as the aorta wraps behind the heart and goes below to the lower part of the body, it changes its name a little bit. So you might hear it called the descending aorta or the thoracic aorta or the abdominal aorta. Still all parts of that vessel. And then it will have specific branches off of that will supply parts of the body. And then as the oxygenated blood reaches like the farthest part of the body, that's the farthest away from the heart. For example, we'll say it's your big toe, okay? There will be capillary beds in that area that will allow for the nutrient and oxygen carbon dioxide exchange of blood that far away. The arteries will eventually turn into arterioles, leading into a capillary bed. On the far side of that capillary bed, then after exchange has been done with lymphatic system and cells and fluid around the capillary bed, the vessels will change their name into venules, and the venules lead into the veins and back to the heart. One thing you have to understand is that the venous system will pump blood back to the heart. It does have one-way valves, but it needs a little help, okay? It's gonna count on muscle movement in order to be able to push the blood back up, especially at the farthest reaches and when we have gravity impacting the flow. Putting in a plug here for movement, okay? Again, movement is part of the reason your lymphatic system flows and your blood, okay? Movement in general, not just the pumping of the heart. So it delivers a little bit of pressure to push stuff back up. Okay, so capillaries. Again, the arterioles will connect with the smallest and most numerous vessels in the body, the capillaries. The average diameter of a capillary is 8 microns. Capillaries are so narrow that red blood cells must pass through them in a single line, one at a time. They are also the thinnest of the vessels. Capillaries are called exchange vessels. This is because of the nutrient exchange and gas exchange that happens across. Also, white blood cells, hormones, things can, because of the thinness of the vasculature in a capillary, the constitution of its walls, this can happen readily. Also, it has pores within the capillaries within which certain things will get to pass. The blood will flow through the capillaries and is controlled by what's called a precapillary sphincter. This is a band of smooth muscle fibers that will encircle the capillary at the arterial capillary junctions, and the contraction of the precapillary sphincter will stop blood flow to the capillary. Relaxation of this muscle will increase the blood flow. Capillaries do not operate separately. They form an expansive network of intertwined vessels called capillary beds, which I've mentioned. Okay, just for a little bit of review here, you might want to review the 3 layers of vessels. Please, I would have an awareness of what vessels carry blood back to the heart, and then the purpose of the precapillary sphincter, as we just mentioned. Okay. The 2 major circuits in the body, I have mentioned this already. Okay, we have the pulmonary circuit on the right side of the heart, and then the systemic circuit on the left side of the heart. Pulmonary circulation, this is the movement of blood from the right side of the heart through the lungs and back to the left side of the heart. We also can call this cardiopulmonary circulation. In systemic circulation, it's the movement of the oxygen-rich blood from the left side of the heart throughout the body. The systemic circulatory system consists of the closed loop network of arteries, arterioles, capillaries, venules, and veins that circulate oxygen, hormones, water, and other nutrients to tissue and carry CO2 out. So when we're looking at the arteries that come from the aorta, if you look at every picture, you're going to notice branches off of that aortic arch. The right and left coronary arteries will branch from the ascending aorta and supply the heart with blood. The brachiocephalic, left common carotid, and left subclavian arteries will branch from the aortic arch and supply head, neck, and arms with blood. These arteries subdivide into many more arteries, including the right subclavian and right common carotid arteries. Many arteries will branch from the descending aorta to supply blood to various organs, as I mentioned. So again, let's look at the branches here. Here is our ascending aorta, aortic arch. Off of the arch, the artery that is the one on the right side of our body, that is our brachiocephalic artery, that will branch off into other arteries. One such is the common carotid. We hear about our carotid arteries frequently, and this is the branching system of how that begins. Also branches into what's called the right subclavian artery. The next main branch off of the aortic arch is the left common carotid. So that one comes directly off of the arch itself, whereas the right common carotid will branch off of the brachiocephalic artery. So there's the difference there. And then the branch off of the aortic arch that is to our far left is our left subclavian artery. Okay, so some of the major arteries in the body, and I'm going to read through some of these. It's good to understand that many of them have names for the region of the body that they're in, or maybe a bone that they're near. Now we learned the body, we kind of layered it. Okay, we went through bones and then we went through muscles. Okay, those names will be relevant in understanding bone names, muscle names, also regions of the body. And this is one example of why. Because as we map out the arteries of the body, oftentimes you can tell where it is by its name if you know the region of the body, the bone, or the muscle that it is near, lies through, or supplies. Same with nerves, really. So some of our major arteries of the body would be the vertebral artery, which runs on both sides of our neck. The brachiocephalic artery, we mentioned that. Axillary artery. Axillary artery is right above or right near your armpit. That's your axillary region. Brachial artery. Intercostal artery. Intercostal. That should tell you, just by pulling that word apart, that we're talking about something with the ribs. Renal arteries. The fact that, that should be pretty straightforward, I think. Your renal system is your urinary system. That's your kidneys. Radial artery, gonadal artery, ulnar artery, internal iliac artery. Again, if you have an awareness of where your ilium is. Okay, actually you have two ilium in the body. One is part of your intestines and one is a bone. They're spelled differently though, and that's how you would be able to determine that. And in this case, we're talking about the bone. The ilium bone is your hip bone, or the top part of your pelvis. Then we have the femoral artery, the popliteal artery, the arcuate artery. Might be a little bit tougher to understand. That's in your foot. External carotid, internal carotid, right common carotid, left common carotid, subclavian artery, the aorta, coronary artery, celiac trunk, superior mesenteric artery, lumbar artery, inferior mesenteric artery, common iliac artery, external iliac artery, anterior tibial artery, posterior tibial artery, dorsalis pedis artery. Now the veins, I'm actually not going to read that chart because they're very similar. Okay. Once again, if you have an artery running through something, most of the time you're going to have a vein traveling the same course, and highly likely it has the same name. There are a few exceptions to that. We don't have carotid veins. We have jugular veins. Okay. So they kind of replace that name and word. Where you have a carotid artery, in general, you're going to have a jugular vein. Then you have a few maybe extra names in either category that you would just have to get used to. One such one would be the median cubital vein that runs across your elbow generally, and it's a connector kind of for your ulnar and radial veins. Okay, then when we actually get into cardiac circulation, or what we can call coronary circulation, this is the blood supply to the actual heart. This is really relevant when they do bypass surgeries and stuff like that. This is generally what we're talking about. So the heart itself, its circulation is highly relevant because this muscle operates differently than skeletal muscle. We cannot have lactic acid buildup here. It has to have oxygen supply all the time so that the muscle itself does not fatigue and does not get damaged. Although it may seem like the blood that circulates through the chambers of the heart would provide oxygen to the heart, this is not true. The oxygen-rich blood that nourishes the heart is supplied by the right and left coronary arteries that lie on the epicardial surface of the heart. The right coronary artery has two main branches, which supply blood to the inferior and posterior walls of the heart. The left coronary artery divides into two arteries, the left anterior descending artery and the circumflex artery, which supply oxygen-rich blood to the anterior, lateral, and posterior walls of the heart. The coronary arteries arise from the ascending aorta and fill when the ventricles are relaxed. The coronary arteries are closed when the ventricles contract. So they're protected from high blood pressure that is generated during contraction. Blood from the coronary arteries flows into two capillaries that carry it to the cardiac tissue, which require oxygen and other nutrients from the blood, just like all other cells of the body. And like I mentioned, keep in mind that the names of the arteries and veins often refer to an organ or a location, or again, bone name, muscle name, etc. Okay. That was a super side note. Okay, this is not new information. Okay, we understand exercise, movement, and its impact on the cardiovascular system and how we can help prevent or change and correct cardiovascular disease. So for a plethora of reasons, okay, movement and exercise impacts this heavily. Again, that's not a surprise. Okay, so let's talk about hepatic portal circulation. Okay, there's something called the hepatic portal system. This plays a vital role in maintaining proper carbohydrate, fat, and protein levels in the blood, whereas the arteries of the systemic circulatory system deliver blood to different parts of the body. The veins of the hepatic portal circulation system will supply blood only to the liver. That's a big deal. The veins that drain the stomach, spleen, and pancreas, and the small intestine and colon will deliver blood to the liver through the hepatic portal vein. This blood is rich with nutrients like carbs and fats, and as the blood percolates through the liver, some of the nutrients are removed, stored, or repackaged for another use. The liver, which plays a role in regulating blood sugar, will store the sugar as what's called glycogen until the body needs the glucose for energy. As someone's blood sugar begins to drop, the liver will break down the glycogen stores and release it into the bloodstream, thereby being able to maintain those blood glucose levels. And that's relevant so the brain gets its proper amount of glucose for operation. Now, when we talk fetal circulation is the process by which an unborn infant will receive its oxygen and nutrients and disposes of the waste products. The umbilical vein will carry oxygen and nutrients from the mother's blood to the infant. Waste products will be cleared through two umbilical arteries in the placenta that will pass through the umbilical cord of the fetus. This process is necessary because the lungs and digestive system have not developed yet, or not developed fully. So most blood will enter the fetal heart through what's called the ductus venosus vein, bypassing the liver and going directly to the right atrium by way of the inferior vena cava. The blood will bypass the right ventricle and is shunted to the left atrium through an opening in the septal wall. This is called the foramen ovale. Small amount of blood does not go to the right ventricle, but it is drained through the ductus arteriosus, which is a vessel that connects the pulmonary artery to the aorta. Shortly after birth, the ductus arteriosus and ductus venosus will close, as does the foramen ovale. So the fetal development of the heart, this will be the start of the development in the what's called the cardiogenic area. The heart's development actually starts from tissue called mesoderm around day 18. During the following week, the primitive heart will undergo 5 developmental changes, so that by the 4th week, the atria and the ventricles are oriented as they are in an adult, with the atria lying superior to the ventricles. At about 4 weeks after fertilization, the partitioning of the chambers will begin, and the primitive interatrial septum begins to fuse when the structure is called with structures called endocardial cushions. Once again, that foramen ovale is an opening in the septum. The foramen ovale allows the blood entering the right atrium to flow into the left until the baby's born, and then it will normally close, or should close. The atrioventricular and semilunar valves form between week 5 and 9, and by the end of week 5, the embryonic heart rate is about 103 beats per minute. By the end of week 9, it's approximately 190. So the blood cells then will begin to develop from what's called a blood island, beginning at week 3, or 15 days after fertilization. Blood vessels begin to form about 2 days later. The blood islands contain what's called an angioblast that form endothelial cells, which will line the inside of every vessel. In this early stage, something called vasculogenesis is happening and is the main process for blood vessel development. The vessels are developed through the process of angiogenesis, which is the formation of the vessels from the pre-existing vessels. Angiogenesis will continue after the baby is born and continue through old age. So during childhood development, the heart will increase in size and weight in proportion to the body surface, or the body mass index. The heart rate decreases with age, blood pressure increases with age. I hope that makes sense. If our rate's decreasing, we need cardiac output to be different. Therefore, we're going to have changes in pressure and such. Obesity, physical activity, nutrition, and environmental pollutants play a role. Now, when we get into adulthood and older adults, the cardiovascular function declines about 10% every decade after age 30. The arterioles and vessels will become more rigid, which will cause the blood pressure to rise. And then when we have that vascular stiffness, this is affected by atherosclerosis, and increases the likelihood of cardiovascular disorders and events. So checking your pulse is one way that we can observe and measure the functionality of the constitution of our cardiovascular system, which is why we get this done. When we take blood pressure, pulse, and respiration, this is kind of all developing or evaluating a way to simply evaluate what's happening. Now, from these measures, can a full-blown diagnosis be delivered? No, you get like a preliminary diagnosis. Okay, then you go for further testing as you do some sleuthing to determine what the cause is. So when you're checking a pulse, you will use the index and middle finger to apply light pressure to any point where an artery is close to the skin. That's called a pulse point. We use it at the radial artery. Usually that's us checking our pulse by our wrist. You can check the ulnar artery too, which would be on the opposing side. That one's a little bit tougher to feel, but if you can't feel radial pulse, ulnar pulse is right there as well. Carotid arteries are how we check on the neck. One thing about checking the carotid pulses is you don't want to do both at the same time. And then you can check at the brachial artery, which is right above your elbow. Okay. The brachial artery is also what you're going to use to auscultate blood pressure. So what you do is you have to multitask here. You have to be able to have your fingertips with not a ton of pressure. Okay, you can shut the pulse off if you push too hard. And you don't want to use your thumb because that may override the pulse you're trying to check. When you have your fingers gently on someone's pulse or your own, you're going to be looking at a stopwatch or a clock. So you have to watch the time, but count the beats. At the end of 15 seconds, you have your number, beats per 15 seconds. So you multiply that by 4 to get beats per minute. Now, when you're palpating a pulse, you're going to feel for its quality as well as its quantity. Doing the number checking how many beats per minute, that's a quantity thing. When we want to do a quality evaluation, we want to say, is it thready? Is it hard? Is it rapid? Is it slow? Kind of thinking. What's it feel like? Now, when we measure blood pressure, again, we're checking systolic over diastolic pressure, okay? We're using the stethoscope. Again, you're going to place this on the brachial artery. You're going to watch the gauge to, as you're listening to what's happening to the pulse in the brachial artery. With inflation of the blood pressure cuff in that area, you're going to be watching the numbers. So again, there's a high level of multitasking here when we're looking at this. Okay, so normal blood pressure, this value, by the way, it depends on what book you're reading. Okay, the changes also, I found out, it depends on what country you're in. Also very interesting to me. So normal is still considered somewhere around 120 over 80-ish. Okay, again, depending on the resource you're looking at. When we say it's elevated a little bit, we're looking at systolic, which is in contraction. Diastole is when it's at rest. So that bottom number is a little bit more important because we don't want the heart to be pressured at rest. When we say stage 1 hypertension, yes, the systolic is up, but also so is the diastolic. Stage 2 hypertension is when we have a systolic greater than 140, but also a diastolic that's 90 or above. When we're talking body mass index, this is, we take our weights and divide it by heights, and then we square it. Okay, so this is a better constitutional measure than just your weight. I wouldn't encourage anyone to just look at their weight because it's an incomplete measurement. I mean, it is a measurement that we need for other things, and we can use it as a reference point, but I wouldn't get hung up on it. There are too many other factors that go into that. When we're looking at cholesterol, this is probably one of my favorite things to talk about. Okay, you get a lipid panel done on your blood draw, your total cholesterol. They like it below 200. Now that value has changed and changed and changed and changed. So I understand that conventionally that's where we like it to be. I don't know that I agree with that. Okay, I think there's more value in doing a calculation of your LDLs and HDLs. I think that is a better measure of cardiovascular risk when you're using these measures. Okay, meaning this, you might have high total cholesterol, but maybe it's because you have, higher level of one over the other, and doing the calculation gives you a better indicator of where you actually stand. LDLs are what we term the quote unquote bad guys, right? They're not bad. They're an indicator that you have inflammation or potentially hormones being created. So if you're high stress, could your cholesterol be up? Yes, indeedy. Okay, because you need that to produce hormones. Cholesterol is part of every cell membrane. Remember that, in your entire body. It's a part of, heavily involved in the nervous system, but also heavily part of your endocrine system and the hormone production. So it's not always the best idea to just shut it down without looking further at why it's going crazy. Like, what's breaking down? Okay, why are we needing this? What's happening? HDLs are the good guys, okay? We like those to be higher. And then triglycerides, if you have high levels of triglycerides floating around in your blood, although they're fat packets, it's an indicator that you eat too many carbohydrates or too many things that turn to sugar really fast in your body, and your body will do a conversion for storage. Okay, on an EKG, this is a little measure of a diagnostic test that we want to look at to understand how we look at the electrical activity of the heart. Now, this guy can tell us a lot, okay, in conjunction with other heart measures. But really, it gives us an indicator of how the heart's beating, how the conducting system is working. Tons of information can be gathered from an EKG. So let's walk through some of the things to look at when we're looking at an EKG. Now, all those little squares, the smallest squares measure 0.04 seconds. Okay, so if you take that times 5, you get 0.2 seconds per one of the bigger blocks. Okay, and that's how you calculate time it takes for the heart to go through a cycle or do a repolarization, depolarization, or contraction. Okay, and the waves and the peaks and the valleys, they all have names, and they all are represented or should represent certain functions within that cardiac cycle. So for example, the P wave, which you have a nice little chart on page 403 in your book, this tells us that the SA node fires and we have atrial depolarization. So the atrium are coming out of polarity when this happens, meaning they're contracting, okay, or they're going to contract. The QRS complex, it's the biggest peak. The R is the biggest peak you see on an EKG, the sharpest one. The QRS complex shows us that the impulse travels to the Purkinje fibers, and then we have ventricular depolarization, which will lead to a ventricular contraction. The T wave, represented here by this nice rolling hill, this represents ventricular repolarization, where the ventricles actually are at relaxation. A U wave, which we cannot always see right after that T wave, kind of, tells us there's a repolarization of the bundle of His and the Purkinje fibers. So like the whole electrical system gets reset in that second. Or the conductivity system gets reset. Okay, so when we talk about dysrhythmias, these are abnormal rhythms. And if we have an abnormal rhythm in the heart that we're able to identify, if it originates in the ventricle, then it's more dangerous. But the origin of the problem can be multifaceted. So in this picture, we are seeing an EKG of what we call a normal sinus rhythm. This is a normal heartbeat. This is what we want to see. Healthy heartbeat. All the waves, all the complexes, all the intervals look great. They match and measure. They're on a good timeline. Now, if we have what's called sinus bradycardia, this is a normal heart rhythm, but with a rate below 60 beats per minute. Common in athletes, slower heartbeat because they're strong. Now, if you're not an athlete, that could be from a different reason. We have sinus tachycardia. This is a normal rhythm, but with a rate above 100 beats per minute. If you have premature atrial contractions or PACs, this is a condition in which an irritable piece of atrial heart tissue will fire before the SA node. This causes the contraction to occur too early in the rhythm. Usually the PACs are harmless. This can be from caffeine, stimulants, or stress. If we have atrial fibrillation, okay, that's letter E on this picture. This will happen if we have atria that's irritated, causing them to beat at a greater rate than 350 beats per minute. And they don't really beat, they shake. Atrial fib is the most common type of dysrhythmia. However, if the ventricular rate is too low or too high, we might need some type of intervention for AFib, and that can be medication. The PVC, or premature ventricular contraction, this is a condition in which the Purkinje fibers will fire before the SA node, causing the ventricles to contract prematurely. Single PVCs are not dangerous. However, frequent PVCs, more than 6 per minute, or multifocal PVCs, meaning those that occur at multiple sites in the ventricle, may be dangerous and therefore require treatment. When we have VT, or ventricular tachycardia, this is life-threatening, and the ventricles will initiate the heartbeat rather than the SA node. We'll notice a heart rate between 150 and 250 beats per minute, and you need to get to the ER if this is happening. VFib, ventricular fibrillation, this is life-threatening when the ventricles will shake rather than the atria. So if you have this, you're not delivering appropriate cardiac output. A heart block. This is a condition in which the impulse traveling from the SA node to the ventricle is delayed, and it's blocked intermittently or completely blocked by the AV node. These are commonly called first degree, second degree, and third degree heart blocks. Third degree heart blocks are the most dangerous because there's no electrical communication between the atria and the ventricles. The atria will fire at the rate of the SA node between 60 and 100 beats per minute, but the ventricles beat at their own rate between 15 and 40. So you have this weird non-concerted effort by the heart muscle. So going through what we just looked at, okay, an EKG is the record of electrical activity in the heart. If you've ever questioned yourself being electrical or a great conductor of electrical activity, this is validation of that statement, okay? And the fact that we use an AED, automatic external defibrillator, we know they sit everywhere in case someone goes into a cardiac arrest where those dysrhythmias become life-threatening or they stop the heart, okay? You can do this to reinstate the rhythms. Also, the fact that you are electrical, okay, again, deals with ion movement and flow, and that is the principle of depolarization within any cell. But when we're talking the heart specifically, it has a specific way that it works to create relaxation and contraction, etc. But it works in that concerted effort as it does. So if you didn't know, if they take a heart out of a person, it beats by itself, okay? And that is because of that ion flow and movement and the electrical conduction principles of the heart itself. Okay, now we touched a couple different times on valve abnormalities. The heart murmur, this is a whooshing or swishing sound. This is the sound that you're hearing. Now it can be created from a few origins. Vascular stenosis is a narrowing of the valves due to stiff or fused valve cusp. This can occur in one or more of the valves, making the heart work very hard to pump blood through smaller than normal valve opening. People with small cases of stenosis, you won't know about it likely, but as it increases in severity, you will likely know it. Now, the mitral valve prolapse. This is the incomplete closing of the mitral valve. The mitral valve This is fairly common. It's occurring in 10% of the population, usually benign and does not require any restrictions. However, in a small number of people, this can create an issue, the regurgitation backward of the blood. Symptoms may include shortness of breath, palpitations, fatigue, and chest pain. Some inflammatory diseases of the heart that we need to touch on. Pericarditis. This is an inflammation of the pericardium around the heart. Causes the heart to rub against the pericardial sac as the heart contracts, which will produce friction and stabbing pains. It can produce shortness of breath, fatigue, and a rapid pulse. Medications are usually what we do in this case. Myocarditis is an inflammation of the myocardium, or the middle layer of the heart, and can cause symptoms similar to pericarditis. Endocarditis is an inflammation of the innermost lining of the chambers and the valves, usually caused by an infection. This condition can destroy the heart valves and cause life-threatening complications. When we talk about heart failure, this is the failure of the heart to meet the oxygen demands of the body. The heart muscle becomes stiff, difficulty filling with blood. Fluid may back up in the lungs, the liver, the arms, GI tract. This can be caused by coronary heart disease and cardiomyopathy. It's not curable, but medications can enhance the heart function. Again, there's that word cure, okay? We can do some interventions that can help. Heart transplants can be used here for end-stage heart failure. When we talk about aneurysms, this is an abnormal ballooning of the blood vessel, usually an artery, due to the weakness of the wall of the vessel. Although the causes of an aneurysm are unclear, hypertension, high cholesterol, smoking can impact this or contribute to the production of this. Okay, once again, aneurysms. This is an abnormal ballooning of a blood vessel, usually an artery, due to a weakness in the vessel wall. Symptoms of an aneurysm can be pain and swelling, but I would say a lot of people may have an aneurysm and they're not aware of it. Common locations will include the aorta, the brain, and the artery behind the knee, and sometimes in the intestines. We would use or want to use CT, ultrasound, and MRAs to truly be able to diagnose it. It would require, to our knowledge, surgery to repair a ruptured wall. That's if it's ruptured, right? If you have an aneurysm, but you aren't aware of it, we wouldn't know if the body would recover it because you wouldn't know it was there if you're not looking for it. So I would say there's potential for recovery. I just don't know how likely that is, and we may never know that answer. So when we're talking coronary artery disease, this is a narrowing of one or more of the coronary arteries. Remember, we walked through that very briefly. Arterial and venous supply to the heart muscle itself. It has a particular pathway it takes in order to be able to supply this. If it's narrowed, it may be due to the buildup of plaque. Plaque develops within the arteries and then can occlude the flow. Now, the plaque often starts with an injury to the tunica intima, the innermost lining of the artery. This injury can be caused by high blood pressure, high blood sugar. So once again, if we have an injury to the vessel wall, then the body does this patchwork thing to it. Depending on how much patchwork has been done to the vessel will dictate the severity of the plaquing and then the occlusion, which is the danger of it. And this is where we want to look at cholesterol. But again, the LDL cholesterol, it is one of the main formers of this, which is why we get, nervous when we see large amounts of it. But again, I would say go inspect where the damage has been done or why the damage has been done. Insufficient blood supply may cause angina pectoris when we're talking about reducing blood supply to the heart muscle itself. Chest pain is the most common symptom that arises from the lack of oxygen to the heart muscle itself, and ischemia, or a lack of blood flow to the heart. Other symptoms include throat dryness, jaw pain, pain in the left arm, nausea, increased perspiration, shortness of breath, and fainting. These are all classic symptoms because they're symptoms that men typically experience. It was long thought, mistakenly, that heart disease was primarily a problem for men, which is why that's directed in that direction. Women do experience heart disease, but they often do not have any classic symptoms. Instead, they're going to have fatigue and flu-like symptoms or experience no pain at all. Nevertheless, cardiac ischemia and angina are just as serious in women as they are for men, but the symptomatology is vastly different. So when we talk myocardial infarction, this is the true heart attack. This is when an artery becomes completely blocked for whatever reason. This can happen suddenly when a piece of arterial plaque ruptures and occludes the artery. Usually there's a big, heavy pressure on the chest when this happens. Early warning signs of an MI will, and if you can, get on top of it soon, you have a better chance of survival. You're supposed to take an aspirin, call 911 within 5 minutes of what you think is happening. Ischemia and injury to the heart tissue are reversible. 20 to 60 minute window before death of the cardiac tissue. So that's good news, actually. For treatment of heart attacks, there's something called fibrolytic therapy. This is drugs that help dissolve clots, and then you can have like an angioplasty done or a stent. We hear all about stents. That's to make sure that the vessel walls don't impact the patency of the blood flow of the vessel so that the blood can flow. When we talk blood pressure, again, this is a big deal as we see it treated all the time. This is the force of the heart pushing blood through the vessels. When we have something known as essential hypertension, we don't know what the cause is, but some risk factors of hypertension: age, obesity, smoking, lack of activity, sensitivity to salt. And that is not a blanket statement. We hear a lot about salt, but that is not everyone's problem. Okay, family history will matter as well. There are so many factors to determine the right kind of treatment for hypertension. The concern is that it's going to stress the heart, also blow out the renal arteries, damage the kidneys, due to the fact, like I mentioned, that the kidneys are so intimately involved in regulation of blood pressure. When we have peripheral vascular disease, or PVD, this is a condition characterized by the narrowing of the arteries in the legs. This results in a lack of blood flow. It is noted that smokers have an increased risk and that exercisers have a lower risk. So to treat PVD, medications to make sure the arteries are dilated, prevent clots, and you can get surgery or stents here as well. Now, if you experience a CVA or cerebrovascular accident, this is, or included in this category would be stroke. You can have ischemic or hemorrhagic. A TIA, this is a transient ischemic attack when there is a temporary lack of blood flow to an area of the brain. Symptoms will usually disappear in 1 to 2 hours. So TIAs are usually like they're letting you know you have issues that you might want to address. So it's a little warning sign from the body to let you know something may go wrong downstream.